Welcome to Season 2 of the Precision Medicine Podcast, sponsored by Trapello. This is the podcast where experts come to discuss the problems oncologists, reference labs, and payers face as precision medicine grows and consider solutions for advancing the quality of patient-centered cancer care. Be sure to subscribe at precisionmedicinepodcast.com to get the latest episodes delivered straight to your inbox.
Welcome to another episode of the Precision Medicine Podcast. I'm Jerome Madison, and today we have Dr. Luis Raez, Medical Director and Chief of Hematology Oncology at Memorial Cancer Institute in South Florida and current President of FLASCO, Florida Society of Clinical Oncology. Dr. Raez, thank you for being a guest on the podcast.
No, thank you very much for the invitation, Jerome. It's a pleasure to share with you and with the audience about this important topic.
Absolutely. Now, I understand that you were born and raised in Peru. Give us a little bit about your upbringing and what attracted you to medicine, and why specifically did you choose oncology?
Yeah, I was born in Peru. My father was a doctor, and my father has lived before in the United States, and he went back to Peru. And he brought me when I was small, and I thought that this was an amazing country. And when I decided to study medicine, I studied medicine originally in Peru. I like the idea to practice in the best medicine in the world. You know, that's why I came to America to learn as much as I can and to use all of these resources that we have to practice medicine. And I became oncologist because it's very challenging, as we discussed before. Things change all the time. We have new medications, and the fight is a very difficult fight. So intellectually, you know, is your whole life dedicated to a cause that is worth to live for, and that's why I choose oncology. And I am involved in the field of lung cancer mainly, and I have decided to dedicate the rest of my life to fight lung cancer and save as many patients as we can, you know, through research, clinical trials, education, advocacy, everything that we can do for our patients, you know?
Yeah. 10 years ago, treating lung cancer in your armamentarium of what you had to treat patients with was very different than it is today. How has the emergence of next generation sequencing testing changed your approach to lung cancer treatment?
It's amazing because we used to use empirical chemotherapy when I started. I started practicing lung cancer in 2001. And that was very frustrating because, as you know, the response rates are low, 30% maybe of the patients. And the survival is like a year. And we didn't have anything better. So the first 10 years were very difficult. We were only able to discover bevacizumab, the monoclonal antibody anti-VEGF. And that really didn't make a lot of difference either. But at least now our patients were able to maybe live, some of them, more than a year. And that is why next generation sequencing is a revolution, because now we are able to customize the treatment and do a personalized medicine, because we know what is the driver for the tumor. So now we are going to find the treatment, the inhibitor for that driver. And that is why it's becoming fascinating, because now we really feel more useful. And I now really feel that we can impact the natural history of the disease of the patient. And that is why next generation sequencing has been so fascinating for us.
Lung cancer has become the envy of other diseases because of the number of targets that they're finding, druggable targets that they're able to find for lung cancer patient. There is an NCCN biomarker compendia, but we still hear a lot about the lack of testing. What do you think the adoption rate for physicians has been for the recommended markers as precision medicine has grown?
Well, if you see the statistics, you know, they are not very good, because depends how you do it. For example, everybody agrees that any new lung cancer patient needs to be tested, okay? But this is a debate if how many times you're going to test it. To give you an example, we started doing testing by tissue. We do NGS in tissue, and you know that probably in America or any part of the world, 20% of the times the tissue is not enough. The sample is insufficient. Okay, so then you took away 20% of the candidates to get precision medicine. So as a doctor, then you have to make a decision. You say, "Oh, I'm sorry, you have bad luck. You are in the 20% that you will never have a molecular marker." Or you can do the extra mile and say, "No, I have now liquid biopsy. I can do NGS in liquid biopsy, so I will test this other 20% with NGS." So there is a major difference in both situations, because if you are only going to test 80%, you are leaving without testing more than 40,000 lung cancer patients in America, because we have a lot of lung cancer patients, 225,000 a year. So that is why, for example, a lot of doctors don't do the extra mile. They say, "Okay, I checked the box, I did the NGS, and I'm not going to be sending a liquid biopsy when I can do chemoimmuno tomorrow." And the patient say, "Oh, yes," because the poor patient, as an average, sometimes patients spend 90 days from the day that they notice that the cough that they have is important to the day that they come to the medical oncology office. So when you tell the patient, "Oh, don't worry, now your NGS is negative, I want to send a liquid biopsy, come back in 2 more weeks," and the patient is like, is already ready to start treatment the same day.
Mm-hmm.
That is why liquid biopsy, NGS by liquid biopsy, is a very, very good option, because even waiting for the tissue is a 4-week waiting. And that is why the success of chemoimmuno is not helping us, because since we have chemoimmuno available, some patients say, "But why I want you to wait 4 weeks? And how about if in 4 weeks you tell me, 'Oh, I'm sorry, there was not enough tissue. We only wasted 4 weeks. I need to do another biopsy and wait another 4 weeks, so I need to do a liquid biopsy and wait 2 more weeks.'" So that is why I think there is a need to be more aggressive in doing NGS for new patients, especially lung cancer. Maybe one solution is to do liquid biopsy in everybody and tissue in the ones that you can. The other problem with tissue also is that, of course, 80% of the time you can get a diagnosis, but a lot of times, for example, I'm in a tertiary center, so meaning that a lot of the patients come from other facilities,
Yeah.
and then I have to order a tissue NGS in a facility that is not mine. So the pathology technician in the other facility gets an order from me to submit tissue to one of the vendors, and the technician may say, "I don't know who is right. Maybe I will do tomorrow. I'm busy today. I'll do in 3 days from today. Or I'm overwhelmed. I'll do next week."
Wow.
And I don't have any pull, any power to obligate the technician to do this, because it's not my hospital, it's not my healthcare system. So that is why that's another disadvantage of tissue. If you practice in a big center, a lot of these samples will be coming from other centers that are not yours. So that's why the delay may be more than 4 or 5 weeks.
Yeah, understood. You mentioned a lot of challenges, but despite those challenges, it seems that every week there are significant findings or reports from studies that show patient improvement, new drug indications or combos or new discoveries. So we asked Dr. Reyes to come on and share with us what he feels were some of the most significant developments in precision medicine for lung cancer patients over the last year. So, um, what are the highlights over the last year that you think are significant for patients and providers to know about?
Oh, there are, there are a lot. Let me see. For example, we can talk about the RET inhibitors. The red is a fusion. It's red RET is a genetic aberration that we didn't have a drug until this year, and it's agnostic, because you can have red fusions in lung cancer, you can have red fusions in medullary thyroid cancer, but also there are red fusions in pancreas cancer, colon cancer, and other cancers. So for the last 4 or 5 years, we have been working with developing 2 drugs for these red fusions, and we were very happy that this year both drugs got FDA approval. The LOXO-292 selpercatinib got approved for lung and medullary thyroid cancer, and Blue, the other company Blue, had the drug approved, prazeltanib, for lung cancer, and hopefully soon for medullary thyroid cancer too. So this is a very important topic because red is present in maybe some people say, oh, it's only 1% or 2% of the lung cancers. Yes, but we go back to the same thing. We have 225,000 new lung cancers a year. So this drug may be important for some thousand, several thousand patients, Plus, if you add the thyroid, and we still are, I'm still having the trial open for the cohorts that are GI. So we're still trying to find if it works for pancreas and colon. So that's why this is a very exciting moment that we have been able to add another genetic aberration to the list that we are targeting, Another interesting development for me is the fact that, we have been attempting to target KRAS for many, many years, because KRAS is a very common mutation in lung cancer, and we were unsuccessful. And we didn't understand why we were unsuccessful. We had tried several times in the last 10 years to target KRAS. But then we realized that KRAS is not only one genetic aberration. We realized that there are many subtypes of KRAS genetic abnormalities, and not all of them behave the same. So that is why in the last years, we start to do research for specific subtypes of KRAS. And for example, for the KRAS G12C, we have a drug developed by Amgen that now is very promissory. I don't know if it will ever get approved or not, because we're only talking about the phase 1 and 2. But the fact that at least now we have a drug that gives a response rate of at least 30% or to 30 to 40%, as it was presented in the last ESMO, for example, last month, is becoming very exciting, because, as I said, this genetic aberration is very common, and we need to discover also inhibitors for common genetic aberrations, because most of the inhibitors that we have now for RET, NTRK, ROS are very, very uncommon. All of them are in the 1%. So we need to really make a home run and discover a drug for more common genetic aberrations that are more common. That's why I think I'm very excited that maybe that we have now the potential to have a new agent, even if the response rate is low. You can say maybe 30%, 40%, but it's better than zero. It's better than put all of these patients on chemo. And you can still put them on chemo. Once that they fail the agent and become resistant, they can still have the current benefit today that is having chemoimmuno. So that is why we are adding another option for the patients, And then another important development this year in precision medicine maybe is the fact that, in lung cancer, that we can use now a combo, ipi-nivo, ipilimumab and nivolumab, without chemo, no? This is the first time that in lung cancer we can use in frontline a combination for lung cancer that doesn't need chemo. Because if you remember, we are using checkpoint inhibitors. We have 3 checkpoint inhibitors approved by FDA for second line, third line, fourth line. But we incorporated all of the checkpoint inhibitors in the front line with the help of chemo. And but this year, finally, we have enough data that if the patients have PD-L1 more than 1% as a biomarker, they can be eligible for ipi-nivo. So that is very exciting too, because it's an option maybe for patients that they don't have a large tumor burden. Maybe they are senior. I work in Florida. I am treating with ipi-nivo a 85-year-old, 86-year-old. Maybe for them it's not easy to take chemo, even if it's a short chemo, because most of the combos that use chemo with immuno are only four cycles of chemo. But that's why this ipi-nivo is a very interesting development. that we were waiting, and now that's another option for us. The other exciting topic is ALK. And first of all, there was a publication in the Journal of Thoracic Oncology from the group of Denver, Colorado. You know, they have been developing inhibitors and doing research for ALK for a long time. And they published the first 100 patients that they treated with ALK inhibitors. It's only a retrospective publication. You can say, oh, that's not very important. But it's amazing to me to discover that the median survival for these ALK patients is 82 months, 7 years.
Mm-hmm.
It's a stage 4 lung cancer patients that are living now 7 years. Remember,
Wow.
we had this conversation saying that oh, my patients live 1 year or less. So now that's why, going back to what you were mentioning before, it's imperative that if somebody is ALK, you need to discover that, because you know that patient can be alive 7 years, and if you don't do the effort with the proper NGS, you are going to deny this patient that survival, because you don't find the ALK aberration. So that is why it's very important, that we find the proper genetic aberration. So in the same field of ALK, in ESMO, finally we have data that lorlatinib, the last ALK inhibitor, now can be used in frontline because it's superior than crizotinib, that is the standard of care for many years. It was the standard of care because it was the first ALK approved. So we have data because, lorlatinib, we have very good data in the last 3 years. With the lorlatinib, you pretty much can rescue any patient that has failed another ALK inhibitor, but we didn't have data in frontline, and now we are waiting for FDA approval because we don't have approval. Also, in the world lung this year, we have another ALK inhibitor called ensartinib, and that also in the data presented in the Presidential Symposium of World Lung show how he beats crizotinib with a much better progression-free survival. And so we have another option with ensartinib for these patients. Also, we are waiting for the FDA approval. But it's exciting because, these two agents are adding to the armamentarium that we have for ALK. So now we have 6 agents approved, and there are still more coming, But these are four major things that I think are being important in the lung cancer in precision medicine that I remember this year,
The Precision Medicine Podcast will continue right after this.
With the explosion of new data and biomarkers in lung cancer today, how can healthcare professionals keep pace to know which genes will best inform treatment decisions? Trapelo knows. Trapelo is the first single technology platform used by oncologists, labs, and payers to resolve the complexities of precision medicine in real time. Trapelo knows which patients to test and when. It knows which tests are most appropriate, which labs are preferred, and which tests are most likely to be reimbursed. Visit trapelohealth.com to learn how you can give cancer patients the most appropriate, evidence-based options when time matters most.
2020 has been an incredible year in so many facets. I mentioned in the intro that you are the current president of the Florida Society of Clinical Oncology. With the challenges with late diagnosis of lung cancer, Dr. Raez, how has kind of this whole COVID, shutdown, quarantine affected the practice of cancer care specifically for lung cancer patients?
This has been terrible because this morning I was telling you I was doing some interviews. I had 8 interviews with TV stations because, as I don't know if you're aware, but in August 6th, there was a JAMA Oncology article that shows that there has been a decrease, 46%, in the number of diagnoses of 6 more common cancers in the United States. And nobody's happy because we're not curing cancer. Normally this will be great news. It's because we know that we're not going to cure all the cancers yet. So we are diagnosing this year 46% less patients that we expected. There is also a report of the COVID Oncology Network that they say the number may be as high as 70%. The National Cancer Institute director was interviewed about this, and he said that if we are delaying cancer diagnosis, for example, in the case of breast and colon, that can mean 10,000 more people dying in the next 10 years because we are going to diagnose more people in the late stage instead of early stage. So instead of going for cure, they're going for palliative treatment. So that is why this is very important. And the same is happening in England, in UK. In the specific case of lung cancer in UK, they say that probably they are going to have 1,300 more lung cancer deaths due to the delays of the COVID. So that is why we're very worried about this. We're doing a campaign at the national level with ASCO and all the patient advocate large groups, and at the local level with Flasco. That's why we're doing this campaign in all the TV radios stations to tell the patients, please come for your checkups, mammogram, lung cancer screening, colonoscopy, PSA. Also, the survivors. When the COVID came, the first group that is not essential to be in the cancer center are the survivors because they're already cured and probably all of them are cured, But so we told all the survivors, oh, don't worry, don't come for your checkups because this is going to be full of patients that are on chemo and we don't need more people in the room. You can, if somebody gets COVID, it's going to be terrible. So a lot of the survivors are postponing his follow-up CAT scan, his follow-up colonoscopy, his follow-up X-rays, his follow-up blood tests. So that's why some of them, the cancer may return, and if we don't find it early, may be too late when we find it. That's why my cancer center, Memorial Healthcare System, and all the other local centers in South Florida, like University of Miami, Jackson Memorial, all of us are doing commercials in TV asking the patients to please come back. It's safe here. It's interesting. Now that we are fully open, the patients believe that if they come to the office, they can get COVID here. But they don't mind to go for a restaurant, and that's why there was a study. I love restaurants, believe me. I'm going to restaurants now because in Florida everything is open. But the chances to get infected in a restaurant is probably higher than the chances to get in the office, because here in the office we use shields, face masks, hand sanitizer, social. We're very strict for social distancing. We don't allow relatives of the patients in the office. We don't allow relatives of the patient in the hospital. So this is the safest place to come now. That's why we cannot keep delaying the diagnosis of cancer.
Yeah. Thank you for that intimate look behind the curtain as to what the physicians are having to do to drive care for patients. You're obviously very passionate about mentoring and educating physicians as well as patients. And you do a significant amount of work in Latin American or Latin countries across the world in Central, South America. Can you tell us about some of your efforts and your conferences that you help lead to improve lung care in those countries?
Yes, the problem that we have in Latin America is that we have what we call middle income countries or low income countries. And that, of course, puts them on great disadvantage because all the new developments that we have been discussing, for example, for precision medicine, they take an extra 1, 2, or 3 years to arrive there. And even if they arrive there, you can understand the cost of all of these treatments make it really, really difficult to practice the same level of medicine over there than here. But at the same time, there is great needs in education and advocacy. So that is why we cannot fix the economic situation of these countries, but we can influence in the education of the doctors and the patients and the advocacy. So that is why I'm very proud that we have a lot of oncologists in Latin America that are very well trained. And one of the reasons is because we interact with them constantly. We publish with them constantly. We are trying to be sure that they know as much as we know here. and they learn what are the latest developments here in United States or in Europe. That's why we do a lot of educational events, and I work with, for example, with ASCO. We have an international group, and we do seminars in Latin America, the same as we do in Africa or in India or in Asia, to try to elevate the level of oncologists. With the ISLC, International Association of Lung Cancer, same thing. We even have an annual or biannual Latin American meeting where we present the latest in lung cancer care in the world for Latin America, and is well attended. And sometimes we also work with ESMO, that trying to improve the training for new researchers and young people in Latin America, and we do seminars over there. So that's why we are trying to do as many initiatives to try to help our oncologists in Latin America be well trained, and be able to one day hopefully to practice the best medicine and as we practice here. But still a big limitation is the fact that, as I said, the economic situation makes difficult sometimes the access to NGS, for example, or the access to new drugs. No.
Yeah. I listened to your conversation with Dr. Jack West on the West Winds podcast, and you spoke about your wife is an infectious disease doctor who runs the AIDS program, I believe, at the University of Miami.
Yes, in pediatrics only.
Yeah. But over that time, since she's been running the program, AIDS has become a chronic disease, right? And she's losing patients, which is fantastic. Do you see a future for lung cancer with the number of targets and the way that liquid biopsy extends the benefits of precision medicine? Do you see a possibility for lung cancers to become a chronic disease of some sort?
Yes, I think I give you the example of the ALK. No, these ALK patients, according to this publication from Colorado, I quote, they live 7 years now, and that's the median. So that meaning that some patients may live longer than that. I have my own ALK and ROS1 patients that are alive now 10 years,
Wow. That's
and
incredible.
that's why we, thanks to precision medicine, we really need to transform or convert lung cancer in a chronic disease. For example, with immunotherapy, if you see the presentation of Dr. Julie Bremer before in ASCO, you see the presentations from UCLA with atezolizumab, and the presentations also for pembrolizumab. We have now 5-year survivors, and these 5-year survivors are with no treatment. So I personally have in my cancer center around 12 people that we give immunotherapy for 2 years, no, according, is pretty much our standard, and then we put them under observation, waiting for them to relapse to start another modality, and they have not relapsed yet. So that's why it's amazing, and we were using target therapy or immunotherapy, but we didn't thought that we may cure people. So at least we're making this disease a chronic condition, because if my patients one day relapse, they are being already enjoying 2 or 3 years without any treatment. So if they even relapse, we can start like again, 3 years without any treatment. We start from you start clean now, or maybe we're curing them. And these patients, for example, with if you get pembrolizumab because your PD-L1 is more than 50%. It's amazing that like half of the patients are alive 5 years. No, maybe this half of the patients are cured. So that's why I'm very, very optimistic now that at least we're making this a chronic condition. Not for everybody, unfortunately, yet, because we need to find drugs for the targets that we already have identified. We have identified targets for 70% probably of the lung cancers, but we don't have drugs for 70%, as you understand. And then and we also need to improve the use of immuno. We are using immunotherapy as much amazing as it is empirically. Really, we are giving immunotherapy to pretty much everybody, and then we sort the patients. No, the ones that respond, they continue immunotherapy. The ones that don't respond, we take them out. With the help of the PD-L1, we are trying to figure it out which ones are going to respond. That's why now we are dividing the patients in PD-L1 positive or no, so they can get treatment. But if you are giving immunotherapy with chemo, pretty much doesn't matter what is your PD-L1. Everybody gets a chemo-immuno combo. So that's why we need really to find a better biomarker for immunotherapy to really do a better precision medicine. For the last 3-4 years, we have a lot of expectations in the TMB, in the tumor mutation burden. But as you know, there is no harmonization yet. Everybody does their own TMB the way that they want, and doesn't seem that they are compatible with each other. Even the definitions of high or low TMB are very different from many different vendors.
Mm-hmm.
So that's why this harmonization project that is ongoing, it has to give us an answer. So hopefully we can agree what's TMB, how to measure, and what is high, what's low. We'll be able to divide the patients better and use a more accurate way, because immunotherapy is very expensive too, and why to put people on side effects if they are not going to benefit from the drug. So that's why this is very important. And talking about discoveries, I don't know if you heard, but in the last 2 years, we have a lot of publications about STK11 and KEEP. And maybe it's time for us to discover genes that can indicate us that immunotherapy is not going to work. They are very valuable because at least we know in which case the immunotherapy is going to work, in which case it's not going to work. So we accurately reserve immunotherapy in the cases to work. I know that the data with STK11 is still controversial, but at least it gives us an idea that discovering something that, like the PD-L1 or TMB, that tell us if it's going to work is so important as discovering something that can tell me that the immunotherapy is not going to work, because in that way we can be more accurate. We can do a better precision medicine with the patients.
Yeah. Dr. Luis Raez, Medical Director, Chief of Hematology and Oncology at the Memorial Cancer Institute in South Florida, and the current president of FLASCO, Florida Society of Clinical Oncology. Dr. Raez, if anybody wants to get in touch with you on Twitter or social media, do you have a platform where they can reach out to you?
Yeah, my Twitter handling is Raez1, and I am in LinkedIn, and it's very easy to get in contact with me. Memorial Healthcare System, I am the medical director here. Is the third largest healthcare system in America that is public. So that's why I'm very easy to find.
And you can always go to precisionmedicinepodcast.com and you can find his social media handles and a way to connect with him there. Now, before we let you go, one very important question, since you being from Peru, what's better, American football or soccer with this football around the world?
Okay, so the Super Bowl is watched by 150 million, no?
Right.
Yeah, the final of the soccer World Cup is watched by 1.5 billion. It's not that it's better. It's only more people watch soccer.
Yeah. Well, once you get out of the United States, I guess it really is no contest.
Yeah, and I don't think there's no reason for other countries not to learn about football. I guess it's a younger sport than soccer,
Well, being an ex-football athlete, my body says I should have chosen soccer. So,
yeah, that's true. There is, that's important.
Dr. Reyes, we really appreciate you giving us updates on the fast-moving world of precision medicine and lung cancers, and thank you for being a great guest on the Precision Medicine Podcast.
No, thank you very much for what you're doing, Jerome. This is extremely important for the doctors, for the patients. I think education is the key to move forward the needle in the fight against cancer.
You've been listening to the Precision Medicine Podcast, sponsored by Trapello. Trapelo is the first clinical decision support tool to align the interests of oncologists, labs, and payers to give patients the best chance at beating cancer. To learn more, visit gettrapelo.com. To subscribe to the podcast or download transcripts of any episode, visit precisionmedicinepodcast.com. We invite you to join the conversation on social media. You can find us on Twitter at PMP by Trapelo or on LinkedIn at the Intervention Insights company page. If you know someone who would enjoy the Precision Medicine podcast, please share it. They'll thank you, and so will we. We hope you'll tune in for the next episode.